I'm Prof. Schil. I'm a thoracic surgeon from the Antwerp University Hospital in Belgium. I'm the current president of IASLC for one more day, and then Professor Zhou takes over, and I will become past president.
So I'm Caicun Zhou from Shanghai East Hospital, medical oncologist. Paul is my friend, always my boss, always. So we use a lot adjuvant targeted therapy, after complete resection for stage 1B to 3A. So we have EGFR TKI. We also have ALK inhibitors. So osimertinib and alectinib have been approved quite effective in early stage of lung. Disease-free survival was significantly improved according to phase 3 trial. So in neoadjuvant setting, we seldom used, TKI. In my mind, the complete response is quite rare with the target therapy. So I prefer to give up patients with adjuvant TKI after complete resection.
I completely agree with Professor Zhou. Let me remind you that when you operate someone, it's important to have a complete R0 resection. So stages 1 and 2 that are clearly resectable, I think we should go on with an operation, not to lose any patients due to neoadjuvant therapy. After the operation, we decide whether any adjuvant therapy is necessary, what we call in high-risk patients, for example, positive lymph nodes, larger tumors, and then we decide we have less ALK and EGFR mutations than you have in Asia, but some cases we will also think when PD-L1 is positive of adjuvant immunotherapy. Regarding targeted therapies, we can only give them after the operation. That's reimbursed. So we look at what EMA, the European Medicines Agency, is deciding. So for the moment, we have the results of the NEO-ADORA study. It just came out, but we don't have any permission now to use neoadjuvant TKIs before the operation. So unfortunately, when we have an EGFR positive patient who needs induction therapy, we still have to give chemotherapy. But we hope it will change in the future. But of course, the combination therapy seems very valid, and combining operation with neoadjuvant, adjuvant or perioperative therapies. But that's something for the near future.
So I prefer to give a patient with G4-in-1 neoadjuvant target therapy. We can combine target therapy plus chemo in neoadjuvant setting. T downstaging is quite easier, better than into downstaging. So in my practice, I prefer to give the patient with G4-in-1 neoadjuvant TKI, maybe plus chemo.
That's a good question. Regarding locally advanced non-small cell lung cancer, we are talking about stage 3A and stage 3B disease. For that, we have developed with the EORTC, European Organization for Research and Treatment of Cancer, some criteria to define what is resectable and what is unresectable. So resectable disease includes those patients that the surgeon is quite confident that he can obtain a complete R0 resection, because that's the main thing we have to do for the operations. Then we have the clearly unresectable ones. For example, bulky N2, when you have lymph nodes as large as the superior vena cava, most of those patients do not qualify, or multi-level with bulky disease do not qualify for surgical resection, even after neoadjuvant therapy. There are some exceptions, but there are not so many. So that's what we're looking at. And then in between, there's a gray zone of what we call, for example, multiple N2 with smaller metastases in the lymph nodes, for example, stations 2 and 4 on the right side, which can be resected. But in those cases, we would like to start with neoadjuvant therapy and then followed by surgical resection. So this is an ongoing process of what is resectable or unresectable. And I have to say, in all the large trials, for example, the Pacific trial, they said unresectable. There was no precise definition. And all the trials of neoadjuvant or perioperative therapy included resectable patients, but again, no precise definition. And that's something we have to figure out in the near future.
I totally agree with what the Paul said. Who make decision which patient is resectable, unresectable, is tumor board.
Tumor board, yeah.
So we must listen to the opinions of the thoracic surgeon. So thoracic surgeon play important role in decision which patient is resectable or not resectable.
Resectable, yeah.
So restaging is very important. So we need a lot of tests. We need PET scan. Even we need biopsy, evaluation of N2, N3 status. That's very important. So we need perform the EBAS in China. So we need PET scan and brain MRI and etc. All these tests can tell you which patient could be resectable or non-resectable. This staging is very important, but we need to talk with the thoracic surgeon, listen to their opinions, right?
The problem with the large trials of neoadjuvant or perioperative therapy was that restaging was only done by CT scan and not by PET CT scan. It was not an obligation to do it. So we know that's really not very reliable. So outside the clinical trial, what we try to do usually is to have a proof of N2 disease by EBUS-EUS. Then we start with the neoadjuvant therapy, and afterwards we do a mediastinoscopy. Because I really think that those patients with persisting N2 nodal disease or even N3 disease, they don't have a good prognosis when we operate those patients. We know that prognosis is quite poor. So probably it's better to give them radiotherapy in combination with immune therapy or chemoradiation. We don't have any good data for that because, as I mentioned, all the trials of neoadjuvant and perioperative therapy included resectable patients, as they call it. So we don't really know whether some unresectable patients become resectable. Of course, we hope for that. Is our dream as thoracic surgeons, that we can convert something that's unresectable on the start, that becomes resectable. But we need more data on that. There are some data that there are less pneumonectomies after neoadjuvant therapy. So, but it's, for the moment, we are not quite sure about that. So there are some trials that will start, that the MDT decides this is really unresectable now from the start, then give neoadjuvant therapy, and then decide whether it becomes resectable or not. For example, also in the Netherlands, there was the INCREASE trial, combining chemotherapy, immunotherapy, and also radiotherapy. And I visited China in April, and I know some studies were ongoing, but they reduced the number of cycles of neoadjuvant chemoimmunotherapy and also reduced the dose of radiotherapy. And what they told me, that they had a pathologic complete response of 40 to 50%. So that's a real improvement of only the neoadjuvant chemoimmunotherapy. That's something we certainly hope for in the future. Yeah.
So neoadjuvant chemo IO produce very good PET-CR, When we look at all phase 3 trial, PET-CR is around 24%, 20%, not bad, For local advanced non-small cell lung cancer, maybe we can give them a kind of neoadjuvant chemo IO. Then we can do restaging to evaluate which patient could become resectable or unresectable. That's my practice. But I also have a lot of discussion with our thoracic surgeon to make decision which patient should be resected, which patient should not. Just give them concurrent chemoradiotherapy followed by IO maintenance.
Yeah. The problem remains also when those patients do not get a complete resection. What do we do afterwards with those patients? And we don't know. So
we have no
should
idea.
you give any additional therapy or not? We don't know. And what kind of therapy should we give?
So if we have enough tissue, we can check biomarkers such as KRAS mutation plus STK11, the KEAP1 mutation, even SMART4 mutation. We all know that these three biomarkers are associated with the poor efficacy of chemo-IO. If patient with these biomarkers, we never give them neoadjuvant chemo-IO, just give them concurrent chemoradiotherapy followed by IO maintenance. So there are a lot of talk on treatment holiday, especially in Guangzhou, So I would say that the cancer never take holidays.
Yes.
We should give them that treatment up to disease progression. But in some cases, they could get very good tumor response. We can use ctDNA to monitoring tumor burden. So when the tumor the ctDNA become negative. So maybe we can give the patient the short period of holiday to stop the treatment. Then we can follow up ctDNA 1 month or 2 months. If the ctDNA become positive, we can restart the therapy. So that's really the great idea. But ctDNA is not approved in China. Testing of ctDNA is not cheap. So nowadays, treatment holiday should not be put into all patients. We just select right patients for treatment holiday.
Yeah, I completely agree, because we cannot really select the patients who we can stop the treatment after neoadjuvant therapy. So it's a work in progress. And in some new trials, more ctDNA will be taken, because it's not just one measure you take or one sample or one level. You have to do it at different times. And then you can compare whether it goes down or not, or when it stays positive or not. So different samples are really necessary. There's a problem. First of all, it's the cost of the medication. It's not cheap medication. And then we have the implementation and the distribution. So I think there are also gaps in the guidelines. We discussed that at the IASLC, also at the board meeting, that we should identify certain gaps for what do they have access or don't have access. And there was an interesting suggestion from Brazil to look in specific regions and countries, so to identify the gaps, but also look at the price of the medication. So they give a numbering of the medication, which should really be essential to have, and then try to implement the cost issue also, so to reduce the cost. So they give a certain value on every medication. And so there's a lot of work to do, especially for the low and middle income countries. And I can compare it a little bit, because we have a lot of experience due to our old colony in Congo with the HIV medication, which was initially also very expensive, but then the companies agreed to lower the price for low and middle income countries. So because we insisted, because the problem was they're much bigger than in Western Europe, so they lowered the price so that everybody has access to HIV medication. And we hope it will be the same for targeted therapies, for immune therapy, and so on.
So it's a tough question. So far, we do not have right answer for this. What we could not accept. Only in the world, only a few people could be treated with best medical care. So we try to increase access to the therapy. What is not easy, economy and cost is 2 keys in determining access to the lower therapy.
Yeah. And we should not forget that in those countries, most of the patients are diagnosed with stage 4 disease.
Right.
So with metastatic disease, that's another thing. So they do not really qualify for perioperative therapy.
So we made some progress in understanding acquired resistance to EGFR, TKI, and ALK inhibitors. But the first thing we need biopsy to get tissue to make multi-omics study, try to find acquired resistance. Sometimes we found histology transformation, So rebiopsy is key for after TKI therapy, So we should do more and more rebiopsy.
Yeah.
After acquired resistance, we made some progress in the treatment. We have 3rd gen. In the near future, we have 4th gen, even 5th gen, the tyrosine kinase inhibitor. I would say that this compound may further improve efficacy. In China, we have several novel compounds have been approved in the 2nd line or 3rd line treatment of TKI failed population. We have TROP2 ADC, we have bispecifics, we will have bispecific ADC, and so on. A lot of many novel compounds come into our daily practice.
I just want to say that in Europe, we don't have access to all those medications I saw in China. So we are quite limited in what we can use or not. And I think the problem is also those patients who have additional mutations besides EGFR or ALK, and how to treat those patients at really good quality medication. For the thymic tumors, so thymic epithelial tumors, unfortunately, we only had batch data. There were not many EDC cases, so electronic data capture, meaning prospectively entered data. But we tried to improve that for the next edition. Or we now created a new thymic database, for example, with the ESTS, the European Society of Thoracic Surgeons, with additional fields to have more data. And those are prospectively sent then to the IASLC. That's what we try to do. Regarding the changes, there were not so many changes. T1 was now subdivided in T1A, tumors until 5 centimeters, and T1B, tumors larger than 5 centimeters. But they all belong to stage 1. So there was no size criterion in the T for thymic epithelial tumors, but that has been changed now. So less than 5 or more than 5 centimeters. But they still belong to stage 1 disease. And for T2 tumors, it was only invasion of the pericardium, partially or totally. But now we have seen that those patients with direct invasion of the lung or the phrenic nerve have a better prognosis than the other T cases, so T3 cases. So they are now included also in T2. So T2 is also involvement of the pericardium, phrenic nerve, or the lung tissue itself. But for the future, we hope to have more data. Those are rare tumors, but that global collaboration with Europe, Asia, there are a lot of cases also in China and Japan, that we can work closely together to have more prospective data on thymic tumors and to refine then our TNM classification and the stage classification.
So that's great. Paul play important role in the thymic and also lung cancer staging.
Yeah.
We have a lot of talk about lung cancer TNM biomarker staging,
Yes.
right? I'm not sure for thymic cancer, can we add on biomarker or something? Well, so far we do not have a biomarker for thymic cancer. In China, we have a lot of ADC compounds. We also have a lot of bispecific ADC. This compound, some of them just approved to treat the EGFR mutant lung cancer. We will have more and more ADC approved. So just a few minutes ago, I represented the data, B7H3 ADC, novel compound from China industry. The compound is well tolerated, produce about 40% tumor response rate in later lines of treatment of extensive disease of small cell lung cancer. The efficacy is quite good. In China, we just perform ongoing phase 3 trial. So we in some section we heard another the novel compound from China, DL3 ADC. The compound is even more efficacious. It produces higher tumor response rate over 70% in second line setting. Unbelievable tumor response rate. So we will have more and more ADC. So this ADC maybe could change our daily practice in the near future.
AI has been introduced and now it's everywhere, so we have to be a bit careful. But I think, for example, now it is certainly worthwhile for radiology, for pathology, for screening already. So we started with a screening program, so they can select those cases where nothing is wrong, that are normal. But I think so the radiologists can more focus on the more difficult cases or the borderline cases that are positive. And the same holds true for the pathology. AI is very helpful, I think, in analyzing a large amount of data. For example, for the staging committee, it will certainly be helpful. But the problem remains if you do not have good data, AI cannot correct for that. It can only do with the data what's in there. And that's sometimes a problem. We think that it can do everything, but that's not true. And of course, for searches, it's very well established that we can help. Regarding my own specialty for thoracic surgery, I don't think AI will take over. They can help us, but they will not do it. And I was surprised when I was in China at the MDT. They asked me about a difficult case, and the patient was there, even a patient with metastatic disease that was controlled, and they had a lung tumor, a large tumor in the right middle lobe. They said, "Would you take it out?" I said, Normally, we should not do it because he has several metastases. So he's just, we would not do it. And I said, yeah, but the patient or the surgeon wants to do it, but we will ask AI. And they put in a patient in their own database. They had validated that. And I was lucky the answer came out, not don't take away the lung tissue. So don't do a lobectomy or bilobectomy. So, yeah. So it can be helpful in our decisions, yes.
So I totally agree with what Paul said. In our daily practice, AI indeed give us a lot of help.
Yeah.
When we come to hospital, AI is everywhere.
Yeah.
So when we try to do translation research, basic research, we need AI.
Yeah.
The huge data cannot be analyzed with human brain. We need AI to do analysis, especially multi-omics. We need AI. AI could change a lot. Nowadays, AI is often used in the radiology, the pathology, maybe only screening of lung.
But we should stay careful and quite critical.
Yeah.
Because even when you type in something in Google, it's done with IA now. So the search is done with IA. So it's but we should remain critical. Yeah. What we accomplished over the last 2 years, I was especially proud of the 9th edition of the TNM classification. It was quite a difficult bird, but we managed to have it. The papers have been published in JTO. So we're now preparing, and that's a job for Dr. Zhou, the 10th edition, and we moved everything statistics to Padua. So we hope that we'll have a very good 10th edition with more incorporation of histology biomarkers and so on. Regarding our worldwide representation, we had the Pan-Africa conference, which was a success. So we'll probably repeat it every 2 years to also go to Africa and other low and middle income countries, as for example in Asia. We have many more multidisciplinary projects now. We have more committees also looking at specific aspects and with a specific purpose. We have the clinical science, we have basic science committee, we have screening committee. So we have a lot also of task forces going on. And lastly, I think we also try to strengthen our journals. So GTO and GTO CRR, so the clinical research reports, to put more strength in them, that they have a very high impact factor now, especially also GTO. So we try to keep the level very high.
I'm kind of lucky. Just after the Paul, Paul is very great president. He set up bar very high. He make our society even more powerful and knowledgeable across the world. Anyway, with help of Paul, also our staff, I think we can do.
Yeah. I will stay around as past president for the last time, 2 years as past president. So Dr. Zhou will only 1 year past president. We changed it for.
I'm first or the last 5-year term of presidency, right? Last 6 years presidency, right?
Yeah.
Anyway, we have Paul, we have our board members, we have our staff. Anyway, we can try to do better.
Yeah.
Yeah.
And we look forward to further active cooperation and collaboration and participation also of the Chinese colleagues. But we need input from China for all the patients. You have the large centers and amazing work you're doing, the new developments there also.